Welcome everyone to our BJJ podcast for the month of October. I am Andrew Duckworth and a warm welcome to you all from your team here at the Bone and Joint Journal. As always, we'd like to thank you all for your continued comments and support, as well as a big gratitude to our many authors and colleagues who take part in the series that highlights just some of the great work published by our authors each month here at the Journal. So today I have the pleasure of welcoming Dr. Brian Chalmers, who is an orthopedic surgeon in the Department of Orthopedic Surgery at the Hospital for Special Surgery in New York, to discuss their paper entitled Risk Factors for Blood Transfusion and Postoperative Anemia Following Total Knee Arthroplasty, which has been published in the October edition of the BJJ. Welcome, Brian. It's great to have you with us. I really appreciate you taking the time.
Thanks, you. It's great to be here, and thanks for having me.
Great. So, Brian, the primary aim of this paper was to investigate risk factors for blood transfusion and postoperative anemia following total knee arthroplasty in a large retrospective patient cohort, with the secondary aim being to attempt to establish a single preoperative hemoglobin cutoff that would minimize the likelihood of blood transfusion while simultaneously maximizing the number of patients at low transfusion risk. So, Brian, maybe as a background to the study for our listeners, can you give us a brief overview of the state of the current literature on this topic as you know it, and sort of what made you look at this question in particular?
Yeah, it's a great question. I think as far as my background and just things that I've been interested in research, I was a resident at the Mayo Clinic and then a fellow at the Hospital for Special Surgery and then stayed on staff. And kind of throughout my career, I did a lot of research on, outcomes, implants, things with fractures and a lot of revisions and a lot of metal and things that were very cool to me at the time. And I think as you go on to practice, you realize that, yes, those are important and very interesting things to look at, but really practice management, patient outcomes around the time of surgery are also very important and things that, I think about and worry about even more than the case sometimes. And so this is something that, has in perioperative outcomes in general, pain, transfusion, patient experiences in general around the time of arthroplasty just matters a lot to me. And so I've focused a lot of my research in my early career and hopefully to come on those types of topics. And so this was something that we've looked at extensively, and especially with the advent of tranexamic acid, looking at transfusion rates and blood loss around the time of surgery, rapid rehabilitation protocols, getting patients out of the hospital faster, really more moving towards a model of a well patient program than more of a sick patient program model. And so, historic transfusion rates, as we talk about in the paper, have been extremely high. And I think we've done a great job with expedient surgery, tranexamic acid, changing our transfusion thresholds to decrease those and get patients out of the hospital faster and in a more safer manner. So that's kind of what inspired me to do this paper, as well as a lot of the other perioperative outcome type of papers that we're looking at.
Yeah, and that's a really nice overview, Brian. I think I couldn't agree more in the terms of as you get more into your practice, you realize that these little nuances that we take for granted, and actually there's a lot of work to be done with, shall we say, the more simpler things, but actually really important things to the patient, like you say. And I suppose related to that, from your time at HSS and maybe for your knowledge of the States as well, how has the practice and maybe indications for transfusion around joint arthroplasty changed, or is it adapted at all, or is there any sort of trends you can see?
Yeah, no, that's a great question. So, I definitely think that we've, revolutionized our blood management protocol as far as, preoperative optimization of hemoglobin levels, intraoperatively doing things, like I said, expediently. We use a lot of neuraxial anesthesia, which helps decrease, blood pressure during the surgery, decrease transfusion rates, blood loss. Obviously, the tranexamic acid has been a huge game changer in the world of blood management. And then I think a big thing is, postoperatively monitoring patients and restrictive hemoglobin transfusion thresholds have been, extremely important and decreasing our transfusion rates, which we know can lead to negative consequences, not only transfusion reactions, but periprosthetic joint infection. So I think that there's been a big shift in the paradigm of blood management and management of the patients in the last 10 to 20 years.
Yeah, no, absolutely. And I think we've certainly seen the same here. And like you say, something we've definitely seen more recently is blood is such a precious resource, and actually we don't, it's not an endless supply, and actually the importance of looking at these things and actually only giving patients who really need a transfusion is a really important thing, whether it be in elective surgery or trauma. So moving on to the study itself, just the design of it, it was a retrospective cohort study. It utilized your institutional database of total knee arthroplasty patients from your large academic tertiary care institution. That was from 2016 to 2020. And that had a total of 14,901 patients that underwent a primary unilateral TKA as an inpatient. So Brian, maybe just very briefly, just as an overview, for who it covers, what were the inclusion and exclusion criteria for the study? Who did you actually look at?
Yeah, it's a great question. So HSS is unique in a couple of ways. One is that, we do the highest volume of arthroplasty in the world. And so there's a lot of patients, a lot of data. And secondly is that we are very traditional in how we do things. Everybody gets preoperative labs. Traditionally, we've had patients stay overnight and get postoperative labs on a lot of patients. We're moving away from that in the last 5 years to doing some more ambulatory surgery. Like I said, treating patients more in a well model. But traditionally, we've had patients stay overnight and gotten postoperative labs on pretty much everybody. And so there's a lot of data in there, and that's why you're seeing such large numbers here. Yeah. Specifically for this study, our inclusion criteria was unilateral primary knee replacements in patients that did stay overnight and got postoperative day 1 labs. So anyone that left the same day, anyone that, and it was only for a diagnosis of osteoarthritis. So anyone with post-traumatic arthritis or AVN or anything like that, or underwent a simultaneous bilateral total knee replacement were excluded. So we were able to capture a large number of patients because of those things that I mentioned.
Yeah, absolutely, very large, and like you say, quite clear indication for it. And you sort of touched upon it then, but in terms of your sort of institution's perioperative protocol during the study period, was that sort of fairly standardized? Did it change at all over that period of time?
It's fairly standardized. There are some differences between tranexamic acid protocols and drain use that changed, and we looked at in this study, which I think is one of the highlights of this study and potential things to change. But overall, as far as the perioperative protocol, everyone gets preoperative labs. Most people stay in the hospital overnight, in this study at least, get postoperative day 1 labs. So that's what we really looked at as far as looking at the hemoglobin levels, blood loss, and those types of factors.
Absolutely. And in terms of the sort of indication for blood transfusion, you've stated it in the paper, but that was fairly standardized across that period of time as well.
Yes, yeah, exactly. We changed to a more restrictive transfusion regimen. I think that most institutions around the country have changed to about 8 to 10 years ago. So that was standardized. And the techniques obviously are a little bit variable between surgeons, but throughout this study period, and we're still doing, most people use a tourniquet for the case. Most people, the vast majority, more than 99%, are done with neuraxial anesthesia and perioperative blocks by our anesthesia colleagues. So overall, pretty standardized besides the few variables that we looked at in this study. So
absolutely. That's great. And in terms of that, the preoperative risk factors and outcomes, what were the main things you wanted to look at?
Yeah, so we wanted to look at things that you can modify, right? Like tranexamic acid use, drain use were some of the big things, operative time, and then some things that you can't modify, and how we can potentially optimize patients better: age, sex, body mass index, and preoperative hemoglobin, as well as ASA class. So those things were the main things that we wanted to study in this paper.
Perfect. And in terms of, before we get on to the results, Brian, in terms of the analysis performed, just very briefly, nothing, obviously not too much detail required, what sort of things were you looking at, and any sort of, so particularly when you're looking at the cutoffs, you set some criteria for that?
Yeah, so we wanted to look at, who had postoperative anemia after surgery, which we had defined as a cutoff of hemoglobin less than 10. And then we looked at transfusion rates. And for this kind of predictive modeling, we looked at a transfusion rate of less than 1%. That was kind of something that we decided that would be, if you have more than 1%, that was, probably clinically relevant.
So Brian, just briefly, before we move on to the results, What were the analyses that you sort of carried out, and in particular the cutoffs you were looking at when you were looking at transfusion rates?
So we had to put some clinical make some clinical decisions and put some cutoffs, and we defined preoperative or postoperative hemoglobin as a hemoglobin less than 10 and a transfusion rate of 1% being clinically relevant, that you would maybe want to monitor patients more closely, or if they had a risk of a transfusion over 1%, maybe want to keep them in the hospital or do additional monitoring or do additional preoperative optimization prior to the arthroplasty. So we made those as our cutoffs for this study.
Absolutely. Yeah, no, that makes a lot of sense. Move on to the results of the paper. So, and what you found. So, like we say, there was almost 15,000 patients included. The mean age of the patients was 68 years, and just over 37% were male. About a third almost had a surgical drain during the procedure, and that was one of the things, like you said, that was a factor you looked at. And the mean operating time for patients was just about around 1.5 hours. So I suppose the main findings, it was sort of the initial findings you found. What were they in terms of the rate of blood transfusions and rate of postoperative anemia, Brian?
Yeah, so this actually kind of surprised me. Our rate of transfusion was 3.7%, which is much higher than I expected. I honestly can't remember the last time that I transfused a primary knee replacement. And so that it surprised me a bit, and that's one of the reasons we, looked at a lot of the analyses further. About 15% of patients had a hemoglobin less than 10 on the postoperative day one labs, and about 25% of patients who had a transfusion had more than one transfusion. So, like I said, that rate surprised me, and a reason that we looked at this and looked at kind of the analyses further, because I think we were all a bit surprised by that transfusion rate.
Absolutely. I think that's a great thing to see, isn't it? When you look at these things, it's not always what you expect. And I think that's one of the great things about then going to look at it further. And in terms of that, what did you find in terms of the associations with regards preoperative hemoglobin levels and gender or sex with these outcomes?
Yeah, so what we found, some expected findings, right? Increased operative time, females just having a lower, preoperative hemoglobin level. But even despite controlling for a lower preoperative hemoglobin level, females in general had a higher transfusion rate, lower preoperative hemoglobin levels, as we would expect. Those patients tended to have higher transfusion rates, lower doses of tranexamic acid. Like I said, in this study period, we hadn't really standardized our tranexamic acid dosing, whether it was IV, topical, multiple doses, and then drain use. I think those were the big things. Drain use leading to increased rates of transfusion and postoperative anemia were the big things that we found to be associated with those results.
Absolutely, and they were also seen on the multivariate analyses that you then did after that, and sort of finally with the results, with one of the I thought there was really interesting things with regards establishing the preoperative hemoglobin cutoff. What did you find, and also which I thought was really interesting, what were the potential cost savings if you sort of extrapolated that out?
Yeah, so one of the goals was of this study was, do we need to get postoperative labs on everybody, right? I mean, that model, moving to more ambulatory surgery, like I said, this model of having a well patient model, do we really need to get labs on everybody? And so we looked at, what would it look like if we said we're accepting a less than 1% transfusion rate? And that was about 13 hemoglobin before surgery. So those patients, unless they're having significant symptoms after surgery, probably don't need any postoperative labs. And so that's kind of what we found. It was a little bit higher than I would, but I wouldn't think that anyone with a hemoglobin above 13 would need a transfusion. But obviously, in our study, there were a few that did. So we found that was the kind of significant cutoff.
Yeah, absolutely. And that, like you said, if you extrapolated that out, there's quite big cost savings, which are interesting. Maybe we can come on to further. But in terms of, I suppose those are the key findings of the study. In terms of the implications of it, I think the strengths and the importance and the clinical evidence are really clear. It's a very large single center study, very well controlled environment in terms of a lot of constants throughout the study period. It's reporting on blood transfusion and postoperative anemia following TKA. As you said, the study really clearly highlights, the importance that increased use of increased tranexamic acid dosing, decreasing the operating time, decreased drain usage may reduce those transfusion rates. and that single preoperative cutoff of 13, like you say, maybe a bit higher than you're anticipating, but obviously aiming for that less than 1%, and that implications that has for sort of post-op labs, as you say. So, Brian, I suppose how do you interpret these findings? And I suppose you've already alluded to, but was it what you expected, and will it change things moving forward, do you think, for you guys?
Yeah, I think it really highlighted the fact that we, need to be a little bit more standardized and critical of our own, blood management strategies at our hospital. I think, since this study and since in the last couple of years, we've really standardized our tranexamic acid dosing and optimizing patients. And, everyone gets a gram of intravenous tranexamic acid before surgery, and we have almost everyone gets a second dose of intravenous afterwards, which I think significantly reduces transfusion rates. We've standardized that. There's very few patients and few criteria that patients don't get a second dose. Our drain utilization at the hospital has significantly, diminished over time. And obviously, preoperatively looking at patients that we can optimize their hemoglobin levels. And we've definitely gone to doing more ambulatory surgery and not getting preoperative labs, even if they do stay overnight, or excuse me, postoperative labs, even if they do stay overnight, with, like you said, with cost savings, with just optimizing patients' experience in the hospital, not having to get a blood draw, not having to get labs, and really kind of standardizing our approach and kind of modernizing everything as we've discussed.
Absolutely, and I think, like as you say in the study, in terms of that cutoff, if you did use a cutoff of hemoglobin, it's about 2/3 of the patients undergoing a TKA would fit that sort of criteria. So that's a huge number of patients. And in terms of how it fits with the current literature, I think you discussed that very well. But is there any sort of limitations to the study that or hindsight with it that you sort of would think really important for the listeners to know?
Yeah, I mean, obviously it's a single institution. There are variabilities that we can't account for that can lead to variability in the study of, especially surgeons kind of do things differently postoperatively. We captured ASA class, but there are certain groups of patients that are on postoperative or preoperative anticoagulation, that have kidney disease and other factors that can lead to higher rates of bleeding, higher rates of transfusion, and higher blood loss. Obviously, every patient after surgery has different cutoffs. Like I said, we use a restrictive transfusion protocol, but patients with cardiac disease or history have higher transfusion thresholds. So obviously not generalizable to every single patient, but I think within the literature makes sense on, and what we found, females and drain use, preoperative hemoglobin level, increased operative times are going to increase your rate of bleeding, postoperative anemia, and requiring postoperative transfusions. And then, like I said, really tranexamic acid has been a big game changer in arthroplasty and even in other fields, general surgery, trauma surgery, and decreasing blood loss and decreasing transfusion rates. So it's been found to be safe in several studies that we've done at the institution and that's been done throughout the world, to not leading to increased perioperative morbidity, has not been shown to increase DVT or PE rates, and has been shown to be safe. So I think institutions should continue to standardize and basically ubiquitously use that to help our patients in the perioperative period.
Yeah, no, I totally agree, Brian. That's a very clear and very fair assessment of it. And maybe just finally, in terms of this area, maybe, you talked about the beginning of the perioperative area. What do you see the future being? What's next with this? Or is there a next area that you feel that needs to be looked at?
Yeah, so I think, we're going to continue this work, and we're actually looking at our total hip population as well to see if there's similar trends. There's obviously minimal patients with drains and total hip replacements. And so looking at different factors and different variables there. And I think continuing to improve and move the needle. Tranexamic acid came out 10, 15 years ago. Is there another thing that, another medication, another technique, that, something that we can do to continue to decrease where that rate of transfusion, not only 3% drops to 0.3%, right? And so, a healthy patient undergoing a hip or knee arthroplasty we hopefully in the next 10 years it should be, no question of whether they're not going to get a transfusion, and that, there's no thought that we're going to even need postoperative labs on that patient. So, just continuing to improve our techniques, and whether it's another advance like tranexamic acid, or just continuing to improve, I think that's what we're all looking at.
No, I totally agree, Brian. I think it's a really nice way to sum it up. And actually, like you say, all these little things add to that ability to make it, like you say, sort of well patient surgery and ambulatory surgery, and getting people through the system in an efficient and safe way. I totally agree. Well, Brian, I'm afraid that's all we have time for. Congratulations to you and your team on a great study. It really added to the literature in this area, without doubt. And thank you so much for taking time to join us. It was great to have you with us.
Thanks a lot, Andrew. Thanks for having me.
And to our listeners, we do hope you've enjoyed joining us, and we encourage you to share your thoughts and comments through social media alike. Feel free to tweet or post about anything we have chatted about here today. And thanks again for joining us. Take care, everyone.